Hello everyone, hope you're all doing good. In this video, we are going to discuss about vulval carcinoma. First, let us discuss what is vulva. Vulva is a global term that is used to all the external genitalia in the female. Okay, so if you see the components of the vulva, that will include your mons pubis, labia majora, labia minora, clitoris, vestibular bulbs, vestibule, even the glands like Bartholin's glands, Keen's glands, urethra and vaginal opening. Okay. So, this is the picture of the entire vulva. Okay, they have shown vulva here. So, that will be starting from the mons pubis, you have the labia majora, labia minora, even the clitoris, the vestibular bulbs. This is the vestibule, the whole opening is the vestibule, followed by the Bartholin's glands, Keen's glands and the openings, especially urethra and the vagina. Now, we have to know one point here. The most common site of vulval cancer is labia majora, and the next common site is labia minora. Okay. The same way, it most commonly occurs on most common side is right side than the left side. Okay. So, these are the two important points you have to know. Most common site is labia majora and most common side is right side. Clear? Right. Now, let's discuss about the lymphatic drainage. So, lymphatic drainage. See, vulval dermis has an abundance of lymphatic plexus. Okay. And it is also connected to the subcutaneous tissue plexus as well, and this will be draining into the superficial inguinal lymph node, followed by the deep inguinal lymph node, and finally this may go to the pelvic nodes. Okay, pelvic nodes in the sense it may go to the external iliac lymph nodes, obturator lymph nodes, or the common iliac or para-aortic. Okay, so this is how the lymphatic drainage is happening in the vulva. Okay, so there is abundance of lymphatic plexus that will be draining into the subcutaneous tissue plexus. Then it will be going to the superficial inguinal lymph node, deep inguinal lymph node, and followed by all the pelvic nodes, especially the external iliac lymph nodes, obturator lymph nodes, common iliac, and finally it will be going to the para-aortic lymph nodes. Okay, yes. And now let's see what is the importance of this lymphatic drainage in vulval cancer especially. Okay, so what happens? The lymphatics that are from the skin of clitoris, labia majora and labia minora will be draining into the superficial inguinal lymph nodes, and then the lymphatic drainage from the glands of clitoris and corpora cavernosa, that is the muscle inside the clitoris. And one important point is here, clitoris, the anterior parts of both the labia majora and minora, and also the perineum. Okay, so these parts, especially the midline parts, Okay, they will be having lymphatic drainage bilaterally. Okay, so that is they can drain into both the sides of the lymph nodes. Clear? Right. So let me tell about the importance once again. So importance. So this guides the extent of surgery. Second one, you have to evaluate the need for lymphadenectomy because there can be lymph node involvement. Then I already told you midline lesions within 1 centimeter of midline means then both the sides of lymph nodes are involved. Okay. Then finally, we are clear that lateral lesions means only the that side lymph nodes are involved. So, only the unilateral lymph nodes are involved. Okay? Yes. Now, let's also talk about something on sentinel lymph nodes. Okay? So, sentinel lymph nodes. So, what are sentinel lymph nodes? These are the first lymph node to get involved directly from the primary site of cancer. Okay. Then prior to detection of sentinel lymph node biopsy and also prior detection of sentinel lymph node biopsy avoids unnecessary lymphatic nodes removal, that is lymph node dissection. Okay, and it avoids the morbidity. So, how it is done? It is usually done by an intradermal injection of blue dye or even lymphoscintigraphy for mapping of lymph nodes. Okay, and you have to know another important fact here, that is the survival rate. Okay, survival rate is for 5 years. If lymph nodes are not involved means it will be about 80%. Suppose if lymph nodes are involved means then it will be only about 50%. Okay, so that much importance the lymph node involvement will have in vulvar carcinoma. So that's why we have to find the sentinel lymph node itself. Clear? Right. And now we are going to discuss about some of the pre-malignant lesions of vulvar carcinoma. So these will include vulvar intraepithelial neoplasia, then lichen sclerosus, Paget's disease. So these are the main things we are going to discuss. But however, squamous metaplasia and condyloma acuminatum also can lead to vulvar cancer. Okay. So now let's discuss about vulval intraepithelial neoplasia. Okay. So vulval intraepithelial neoplasia means you have to know 80% of these cases are associated with HPV infection. Okay. And these are chronic infectious conditions which will turn into inflammatory conditions because there will be mutations in the P53. Okay. That is seen mostly in the older women. So, we have 3 types of VAN that was given by ACOG in the year 2019. Okay. ACOG is American College of Obstetrics and Gynecology. Okay. So we have vulval USMLE first. Okay. Low grade squamous intraepithelial lesion followed by vulval high grade squamous intraepithelial lesion, and finally we also have differentiated VIN, vulval intraepithelial neoplasia. Clear? Right. Now we will see about USMLE, that is low grade squamous intraepithelial lesion. Okay, so this is how it will be converting. First, if there is any change, any chronic inflammatory condition or infectious condition, or there is a change in any of the genes like P53 mutations, what will be happening is there will be low grade squamous intraepithelial lesion. The lesions will be very low and it will be confined to one only a certain region. Okay, then it will be becoming a high grade, then it will become differentiated, and once it is going to breach the basement membrane and has the capacity to go invasively and also to metastasis to other parts, it will be carcinoma. Clear? Now, low grade squamous intraepithelial lesion is mostly a HPV infected lesion which will be presenting as flat lesions with basal atypia. There will be coilocytic changes and it is also self-limiting condition. Okay, whereas vulval high grade squamous intraepithelial lesion means these are multi-central or even multi-focal lesions. Okay, and these are mostly seen in young women. And here oncogenic HPV virus infection is seen, that is by the 16, 18 types like that. Okay, then it can be associated with other STDs as well. Clear? Right. Next is differentiated vulval intraepithelial lesion. So, differentiated vulval intraepithelial lesion means they will have either unifocal or unicentral lesions. Okay, and this is associated with dermatologic changes like lichen sclerosus, and it is associated mostly with the older women. Okay, so these are the three types of vulval intraepithelial neoplasia. Right? Okay. Now, let us see how will this vulvar intraepithelial neoplasia will present to you. Okay. So, clinical presentation. Let's talk about the symptoms first. See, most of the times the women will be asymptomatic. Okay. However, if there is a presentation, it can be with pruritus, which is the most common presentation, then followed by burning sensation or pain. There can also be superficial dyspareunia. Clear? Right. Now, what are the signs we can see? So, these are usually well-defined lesions. Okay, so they are well-defined lesions which will have white, hyperpigmented keratotic block. Then there can be ulcerations as well. And one more thing, already I told you, differentiated vulvar intraepithelial neoplasia can be associated with other conditions like lichen sclerosus. So, you will be able to see the signs of lichen sclerosus as well. And yes, some cases inguinal lymph nodes will be palpable also. Clear? Yes. So, these are the signs. Usually, they are well-defined lesions with white hyperpigmented keratotic blocks, or there can be ulcerations. You can say other lesions like precursor lesions like lichen sclerosus as well as the inguinal lymph nodes can also be palpable. Okay. Now, let's see about the diagnosis. So, diagnosis, either you can make it clinically itself or you can go for colposcopy biopsy. Okay. So, how you will take this colposcopy guided biopsy means you have to stain the lesion with 3% acetic acid for 5 minutes, and after that the lesions will appear as aceto-white areas. Okay. Suppose if there is a high grade lesion, it will appear as coarse punctuation, okay, especially of the vessels. Okay. So, then the biopsy can be taken using case punch biopsy forceps. Clear? Yes. Then let us also discuss how to manage this condition. So, management, first you have to prevent against HPV infection. So, prevention of HPV infection by immunization. Okay. Then you can also go for local excision or laser ablation. You can also go for CVSA, that is cavitational ultrasonic surgical aspiration. Topical application with imiquimod. Okay. Now, let us discuss about lichen sclerosus. Okay. So, lichen sclerosus is the most common lesion of vulva. This is usually white in color. It is associated with autoimmune dermatoses. So, it can be associated with other autoimmune conditions as well, like SLE, etc. Okay. Then, yeah. So, usually the presentation will be with pruritus, burning sensation, dyspareunia, dysuria. Okay. And the signs, when you examine how the lesion is like, so this is a lesion of lichen sclerosus. So, it is usually white paper like lesion, and the skin will be very much thin in this condition. The introitus, okay, can you see the introitus? It has become very narrow. So, the introitus becomes narrow, and if you look in some lesions, because of the constriction that is happening, what happens? The entire vulva will be taking the figure of 8. Okay. Yeah. So, diagnosis is usually with the biopsy using case punch biopsy forceps, and this is the histopathological examination of lichen sclerosus, where you are able to see thin hyperkeratotic epithelium. Yes, that is hyperkeratotic, that is atrophic epithelium. That means the epithelium has become thin. Okay. Then you will also be seeing hyalination or hydropic degeneration of the basal cells. Okay. So, you see hydropic degeneration of the basal cells here. Yes. Then you will be seeing homogenization of the collagen on the top of the dermis. Okay. There is sclerosis of subepithelial region. You can also see flattened reed pegs, and there will be so much of infiltration of lymphocytes as well as the plasma cells. Okay, there is infiltration of lymphocytes and plasma cells. Clear? Next one is, how will you manage this condition, lichen sclerosus? So, management is usually by topical steroids, or we can also offer them emollients. Okay, and for this condition usually surgery is not needed. And yeah, next disease we are going to discuss is Paget's disease. Okay, this is also a precursor lesion. So, this is a non-squamous intraepithelial neoplasia of vulva. Okay, so here the symptoms will usually be like they can have itching, soreness, or even bleeding. Okay, and the signs will include, they will be looking like a well demarcated lesion, and they will usually look, see, the demarcation is clear, right? So, this is a Paget's disease of vulva. The demarcation will be very clear and they will be usually red color, indurated as well as eczematous lesion. Clear? Now, let's see what will be the investigation. We will be taking biopsy using case forceps. So, if you take histopathological examination, you will be able to see Paget cells. See, you are able to see so many cells that has intervened in the dermis, right? So, that is Paget cells, and these are large pale cells with vacuoles. Okay. So, Paget's disease is not seen only in vulva, it can be seen in other organs like breast, cervix, etc. Okay. Management will go for a local excision or vulvectomy, and this condition may also need lymph node dissection. Clear? Yes. Now, let's go into the actual discussion of vulval carcinoma. So far we have discussed about the anatomy and the pre-invasive lesions of vulva, right? Now let's discuss about carcinoma vulva. See, carcinoma vulva comprises of 3 to 4% of all the gynecological malignancies. Okay, and it is mostly seen in the postmenopausal age, especially more than 50% of the cancers are seen in women who are more than 70-year-old. Okay, so average age of incidence can be around 62 also, but more than 50% of the cases are seen in women who are 70 years and above. Okay, right. Now, let's discuss about the risk factors for vulval carcinoma. So, risk factors will include increasing age. It can be due to HPV infection. Yes, we have seen how the pre-invasive lesions are going to come through HPV infection. Then smoking. Then some of the inflammatory conditions that is affecting the vulva. Also, any prior radiation or immunodeficiency, nulliparity, and the so far discussed pre-malignant conditions. Okay. So, these are the risk factors for vulval carcinoma. Increased age, HPV infection, smoking, inflammatory conditions, prior radiation, immunodeficiency, nulliparity, and the pre-malignant lesions of vulva we have discussed so far. Clear? Right. Now let's divide the age group into comparingly young women and comparingly older women. Okay, so let's take 55 years as a cutoff. So the women who are less than 55 years will be younger age group, and the women who are more than 55 will be older women. Okay, so the most common cause for vulval carcinoma in young women will be HPV infection, smoking, or even immunosuppression. Okay, whereas in older women the causes will be dermatological conditions like lichen sclerosus or any genetic mutation. Yes, HPV infection is also possible in this age group, but HPV infection will be constituting about only 15%, and mostly these women will be non-smoking only. Okay, so if you see the lesions that are occurring in young women, that will be multifocal and multicentric type of lesions, whereas in that is occurring in older women will be unifocal and unicentric, and the prognosis in young women will be good, whereas the prognosis in the older women will be bad. Okay, now let's discuss about the types of vulval carcinoma. Okay, so types of vulval carcinoma. It is basically classified into three histological types. Okay, so one is warty, second one is basaloid, and the third one is keratinizing. Okay, so if you take the warty and basaloid type, this is mostly seen in people who are above 40 to 44 years, and it is associated with HPV infection. Okay, and the keratinizing type is usually seen in older women, and these are usually HPV-independent lesions. Okay, however, the keratinizing type constitutes about 60 to 80% of the squamous cell carcinoma of vulva, and it may occur anywhere on the vulva, and it is mostly found in the labia, majora and perineal region. Okay, so squamous cell carcinoma is the most common histological type of vulval cancer, and vulval intraepithelial neoplasia is the precursor lesion for squamous cell carcinoma. Okay, now let's discuss about Paget's disease. Okay, so Paget's disease of vulva. See, extra-mammary Paget's disease. Okay, I have told you already, Paget's lesions can occur anywhere, say in the breast or in the ovary, cervix, etc. But this is an extra-mammary Paget's disease which is occurring in the vulva, and it mostly affects the apocrine gland bearing skin, that is comprising of 1 to 2% of the malignancies. Okay, and this is mostly seen in older women who are in their 7th decade of the life, and pruritus is the most common presenting symptom. Histologically, as we have seen, you will have epithelial tumor cells in them with clear cytoplasm. Okay, so these can either occur heterogeneously or it can be founded by the immunohistochemical markers of vulval disease, that is including cytokeratin 7, CEA, pan-CK and EMA. Okay, so this extra-mammary Paget's disease can grow for years, and after that this may invade through the dermis but the spread here will be rapid and aggressive as well through the lymphatic or even hematogenous routes. Clear? Yes. Now let's discuss about this another subtype of vulval carcinoma. So the etiology of verrucous carcinoma is unknown. Also, there are no precursor lesions for this condition. Okay. Histologically, verrucous carcinoma is a well differentiated tumor which has marked epithelial proliferation and this will have minimal nuclear atypia also. Okay, and this tumor expands with reed ridges which are elongating, and this is the characteristic feature of this cancer. So these elongating reed ridges will be going into the dermis so that it will be causing a pushing pattern. Okay, it usually pushes the dermis rather than a infiltrating pattern, and proliferation is primarily seen at the basal and parabasal layers. So for identification, there is an increased expression of the cellular proteins like cellular proteins like increased Ki67, MCM2 and TOP2A. Okay. So how will you treat this condition? You have to go for a local excision. Clear? Yes. Now let's discuss about sarcoma. See, there are so many sarcomas. The most common sarcoma of vulva is the leiomyosarcoma. Okay. However, dermatofibrosarcoma, protuberance, then epithelioid sarcoma, malignant, fibrohistiocytoma and also synovial sarcoma or the various types that can be seen. Clear? Let's discuss about vulval melanoma. Okay. See, there are three types of vulval melanoma that exists. The mucous lentigus type is the most common, and there are also nodular and superficial subtypes. Okay. So the vulval and the cutaneous melanomas usually share the common immunohistochemical markers like S100B, HMB45 and melan A. Okay. And there will be mutations in the cell regulatory proteins as well, like CKit or PDL1. Okay. In the 5th to 7th decades, mostly it is seen in white women, and these lesions are mostly confined to the clitoris or the labia minora. Okay. And the best predictor for this lesion is by Breslow's depth of invasion. Okay, and you have to also check about the lymphovascular space invasion. Surgical resection should be done with adjuvant medical therapy. Okay, yes. So this is a picture of melanoma. So here you are able to see the melanin containing pigment, which is black color. So you are seeing a black color lesion. Okay. So this picture I kept it to demonstrate about the general appearance of vulval carcinoma. So you will have a growth, and this lesion is in the midline, right? So since it is in the midline, you have to think about the bilateral lymphatic drainage. Okay. Yes. Now let's discuss about the biopsy. So biopsy can be taken as an incisional biopsy or an excisional biopsy. Incisional biopsy means this will include the transition part as well as the healthy tissue also. Okay. Excisional biopsy means the whole tumor mass will be removed as such. Okay. There is also another type of biopsy, that is radical excisional biopsy, where you will remove the whole mass and also the surrounding 1 centimeter healthy zone as well. Okay. So let's discuss about colposcopy, and here in case of carcinoma vulva, it can be specifically mentioned as vulvoscopy also. Okay. So colposcopy or vulvoscopy. Okay. So usually vulvoscopy directed biopsy can be done, and already as I told you, it can be done after painting it with 3% acetic acid for 5 minutes. Okay. Entire vulva has to be examined, and you will be seeing aceto-white areas as well as abnormal vascular pattern also. Okay. So this is a case punch biopsy forceps. It is case punch biopsy forceps, and this will be used when there is deep invasion of the tissue. Okay, say it is more than 4 mm means we will be taking a biopsy using this forceps, that will be including the epithelium as well as the stroma. Okay. So multiple biopsies or single biopsies can be taken. Other than in clinically significant carcinoma, any new lesion or change in the epithelium, especially if she is a postmenopausal woman, should be biopsied. Okay. So the changes will include change in color, there will be appearance of surface irregularity or a newly appeared wart or even a polypoidal growth. Okay. Other than this, you can also offer her investigations like cervical cytology, okay, inguinal lymph node fine needle aspiration cytology, then computed tomography scan of the pelvis and inguinal areas, X-ray chest and bone. You can also offer her a complete hemogram, blood sugar, lipid profile, liver function test, kidney function test, etc. And for discovering the nodal lymph node involvement, we can also go for CT scan, MRI, positron emission, tomography, etc. Okay. You have to understand one fact that lymphography is superior to CT scan. Okay. So, that is intradermal injection of blue dye has to be done to identify the sentinel lymph node. Okay. Right. Now, let us discuss about the staging of vulval carcinoma. Okay. So, staging, this was the new updated staging that was given in 2021 by FIGO. Okay. So, let me discuss about the stage and the description. Okay. So, we have 4 stages actually. Okay. So, first one is the stage and the description. Okay. Yes. So, first stage is a tumor which is confined to the vulva. The tumor is confined to the vulva. Okay. So, this is further divided into 1A and 1B. It is further divided into 1A and 1B, and it is based upon the tumor size and invasion of stroma. Okay. So, I am telling you how it is divided and what is the component that is dividing them. Now, let me tell you the cutoff. Okay. So, 1A means the tumor size is less than or equal to 2 centimeter. Okay. And the stromal invasion is less than or equal to 1 millimeter. The same way, this will come to 1A, 1B. Okay. 1B means the tumor size is more than or equal to 2 centimeter, more than 2 centimeter, and the stromal invasion can be more than 1 millimeter. Clear? Right. Now, let us see about the second stage. So, here also I am going to tell you the stage and the description, okay, and the criteria for division. Okay. So, stage 2 does not have any much description. So, here this tumor can be of any size, but there will be extension to the lower 1/3 of urethra, lower 1/3 of vagina, as well as lower 1/3 of anus. One important point here is there will be negative nodes. Okay. Then coming to stage 3, this is a tumor again of any size. Okay. But there will be extension to the upper 2/3. Okay, upper 2/3 of urethra, vagina, bladder mucosa, rectal mucosa, regional lymph node metastasis will also be here. That is the very important point. Okay, there will be regional lymph node metastasis. There will be regional lymph node metastasis. Okay. Now, let us see about the various subdivisions of stage 3. Okay. That is stage, what is the criteria and description. Okay. We have stage 3A where the tumor can be any size and it can involve the upper 2/3 of vagina, vulva, bladder mucosa or rectal mucosa, and there will be a regional lymph node metastasis, but it will be less than or equal to 5 millimeter. Clear? Then coming to stage 3B, there will be regional lymph node metastasis, but it will be more than 5 millimeter. Okay. Stage 3C is also there. It will be more than 5 millimeter, but there will be extra capsular spread of the tumor. Clear? Let's discuss about stage 4. Okay. So, stage 4 is something where the tumor can be of any size. It can be fixed to the bone, or there can be ulcerated lymph node metastasis, or else there can be distant metastasis also. Okay. So, what is 4A and 4B? Okay. So, 4A means the tumor is fixed to the pelvic bone and there is fixed or ulcerated lymph nodes that will be of the regional lymph nodes. Okay. Then stage 4B means it is to the distant organs. There will be distant metastasis. Clear? Yes. Now let's speak about the spread. So, spread of the tumor, direct spread will be there. Okay. So, direct spread can happen to the vagina, urethra, urinary bladder, anal canal, as well as the pelvic bone. Okay. And when we speak about the lymphatic spread, lymph node involvement can be seen in percentage according to the stages I am giving you. Okay. So, in stage 1, there can be 10% of lymph node involvement, whereas in stage 2, there can be 30% of lymph node involvement, and in stage 3 it is about 70%, and in stage 4 definitely there will be 100% of lymph node involvement. See, hematogenous spread also is possible and it can rarely occur. Clear? Right. Now, let's discuss about the management. See, management is usually by surgery. Okay. And radiation can also be added in advanced stages, say stages 2 to 4. Okay. You can also give chemotherapy by using cisplatin, bleomycin and 5-fluorouracil, etc. Okay. Let's discuss about the types of surgeries you can offer them. So, types of surgery you can offer them will include wide local excision or a simple partial vulvectomy, okay, or a radical partial vulvectomy, or it can be a radical total vulvectomy also. Okay. So, wide local excision means you are going to do only a excision of the tumor. Simple partial vulvectomy means you will be removing the that side vulva completely. Okay, one side of the vulva completely. Radical means you will be adding lymph node dissection. That's it. Okay, so radical partial vulvectomy means one side of the vulva will be removed along with the lymph nodes, and radical total vulvectomy means total vulva will be removed along with the involved lymph nodes. Clear? Right. Now, Inguinofemoral lymphadenectomy is the type of lymphadenectomy that is done with radical partial vulvectomy and radical total vulvectomy. Okay. So, in cases of removal, at least 1 centimeter of marginal disease free area should be there. Okay, so that it will reduce the risk of recurrence. Clear? Now let me also tell you about the stage-wise treatment of vulval cancer. Okay, so stage-wise treatment of vulval cancer. For stage 1A, when the stromal invasion is less than 1 millimeter, you can do a wide local excision. Because there is no lymph node involvement, you don't need lymphadenectomy. Sometimes you can even offer a simple partial vulvectomy. Okay, but anyhow, wide local excision is more than enough, right? And for stage 1B, okay, when the stromal invasion is more than 1 millimeter, you have to offer them wide local excision with ipsilateral inguinofemoral lymph node dissection. Okay, and second one, you can even offer bilateral inguinofemoral lymph node dissection when there is involvement of labia minora, because it is coming more to the midline, right? Labia minora, and if the lesion is within 1 centimeter of the midline and there is lymph node involvement on opposite side. Okay. So this is wide local excision with ipsilateral inguinofemoral lymph node dissection. The same way it is bilateral inguinofemoral lymph node dissection. Clear? And coming to the stage 2, you will offer her larger radical partial excision and bilateral inguinofemoral lymphadenectomy. This can be combined with radiotherapy also, but it can be avoided also sometimes. Okay, it depends upon the status of the patient. It has to be individualized, and also it depends upon the preference of the patient as well. Okay, then stage 3, you will do a primary radical surgery if possible, or you can also offer her primary, this is not followed by, or you can even offer her primary radiation. Okay, so if you offer primary radiation, there will be shrinkage of the tumor, and this can be offered for at least 5 weeks in fractional doses. So after this primary radiation and the tumor size has shrunken, then you can offer her surgery. Clear? Yes. And next one is stage 4. Here you will offer her primary radiotherapy or primary chemotherapy as well. That will be followed by excision of tumor. Okay. Now let's discuss what are the complications of doing surgery. Okay. So complications of doing radical vulvectomy. So immediate complications and late complications we have. The immediate complications will be wound infection. There can be thromboembolic complications or secondary hemorrhage. There can also be osteitis or paresthesia of the upper legs. Okay? Yes. Now coming to the late complications, there will be disfigurement of vulva, or there can be vaginal introital stenosis. Then definitely there will be impairment of sexual function. There will be leg edema or lymphedema. Fecal and urinary incontinence can also be there. There can be complication of radiation. Okay, radiation complications. So, because of this, we have to follow up all the cases regularly. Now, let's discuss about the prognosis of vulval cancer as given by FIGO. So, stage 1 has, I am giving the 5-year survival rate. Okay, 5-year survival rate. Okay, so stage 1 has 90% 5-year survival rate, stage 2 has 75%, stage 3 it is about 54%, and in stage 4 it is about 16%. Clear? Right. So, with this we are finishing the discussion on vulval cancer. We have started with the anatomy as well as the pre-invasive lesions of the vulva, and we have dealt in detail with the vulval carcinoma staging and management. So, this is all about vulval cancer. Let's meet in the next video. Until then, keep going, happy learning, take care and bye-bye.